The session is co-endorsed and supported by the Singapore Cardiac Society with APSC in collaboration with Impulse Dynamics. My name is Jack. I'm the current president for the Asian Pacific Society of Cardiology. I'm an interventional cardiology based in Singapore, so I'm very eager to learn more about CCM therapy from my esteemed panelists. The first speaker is Professor William Abraham, Professor in Internal Medicine and Chief of Division of Cardiovascular Medicine at Ohio State University, the USA. He's going to speak to us on assessing heart failure, how we are doing and what are the gaps. This will be followed by Professor Andrew Coates, Director at Monash Warwick Alliance from the UK. He's going to introduce to us the CCM therapy, the correct patients, and identification of therapy selection. Last but not least, we're going to finish up with Dr. Emad Aziz, Professor of Medicine at the New Jersey Medical School from the US. He's going to share with us a case study followed by an interesting discussion on CCM therapy. With me today, my esteemed panelists, I'm very privileged to have Dr. Azmi from National Heart Institute, Malaysia, as well as Professor Chin Chi Kiong, my colleague from Singapore as well, both electrophysiologists. We also are very privileged to have Professor David Sim, my good colleague, who is a director of heart failure service at my center in National Heart Center, Singapore. This webinar is copyrighted by the APSC and should not be distributed without the prior permission of the APSC. The views and opinions expressed in this webinar are those of the faculty members and do not necessarily represent those of the APSC. The content is currently live streamed by Wonder, APSC Facebook, as well as YouTube pages. This webinar is endorsed by EBAC for CME points for attendees who attend the full session. For Singapore registered physicians, CME point will also be accredited for those attendees who attend the full duration of the webinar. You will receive your certificate of attendance upon completing a survey sent by email post-webinar. For the live attendees, feel free to click on the Q&A button to ask the questions and I'll endeavor to answer all of them. Let me state the objective for today's session. We would like to review the need and assessment tools for diagnosing heart failure and the NYHA classification and what are the gaps thereof. We want to discuss guideline-directed medical therapy for the treatment of heart failure. Where are the current treatment gaps and goals? And for this particular session, we want to introduce CCM technology and indications for the patient selection and where is its niche application. We also would like to review the mechanisms of action around CCM technology. A plug for APSC, we have some upcoming webinars on the 29th January for fellows teaching course, a professorial round hosted by Professor Tan Hui Chim, a Save a Life session, narrating a teaching round on unusual cases of AMI. 5th February 2021, we have an APSC Champions League where we get our best in the region to present their most memorable teaching case in STEMI care. So stay tuned and look out for these upcoming sessions. So let's get started. And for the first lecture, we have Professor William Abraham to talk to us about assessing heart failure. How are we doing? Prof. Abraham, please.
Welcome. I'm Bill Abraham from the Ohio State University, and it's a pleasure to join you for this APSC webinar on cardiac contractility modulation. I'd like to spend the next 15 minutes talking about the assessment of heart failure and how are we doing. My disclosures relevant to this discussion are shown on this slide. First, let's begin with a review of the epidemiology of heart failure in the US and around the world. According to US statistics, there are currently about 6.5 million Americans who have diagnosed heart failure. The annual incidence is nearly 1 million, new cases per year, with about 310,000 annual deaths. The mortality rate is about 50% at 5 years. Heart failure also results in a large number of hospitalizations, more than 1 million each year in the United States, and a larger number of outpatient office visits totaling 6 to 12 million annually. Finally, the costs of heart failure care in the US are in excess of $30 billion. Thus, heart failure represents a major and growing public health problem, resulting in substantial morbidity and mortality. It is also associated with a high degree of disability. And by 2030, the prevalence will increase to more than 8 million Americans, and the total costs will increase more than 120% to about $70 billion. And finally, heart failure is not just a problem in the US, it's a worldwide problem affecting at least 26 million people. Now, as mentioned, heart failure leads to substantial disability, that is a substantial reduction in quality of life, and a high symptom burden on a daily basis, resulting in substantial exercise intolerance and a limitation in functional capacity. The physical, social, and emotional impact of heart failure is reviewed on this slide. You can see that about 2/3 of heart failure patients have mobility problems, 2/3 report some kind of pain or discomfort. About 75% find it difficult to carry out usual activities of daily living. 24% struggle to take care of themselves, and about 50% have anxiety or depression. Therefore, improving heart failure symptoms and quality of life, including physical activity, continues to be a large unmet medical need in patients with heart failure. So who manages heart failure patients? Well, based on US data, most heart failure patients are managed by primary care physicians. Cardiologists are primary managers of only about 17% of the heart failure population. So as I'll conclude at the end of this discussion, collaboration between cardiologists and primary care physicians in the assessment and management of heart failure patients is critical. What are our heart failure treatment goals? Well, there are many. We want to improve functional capacity. That might be measured as improvements in 6-minute hall walk distance or peak VO2. We want to improve symptoms and health status, including quality of life and the New York Heart Association functional class ranking. We'd like to reduce the risk of heart failure-related hospitalizations, improve survival, and implement proactive clinical care, optimizing drug and device therapies to achieve these goals. So now let's talk about the assessment of heart failure patients and how we classify them. There are a number of classification systems in use to describe heart failure patients, but the two main ones are classification based on left ventricular ejection fraction and classification based on functional status. Let's begin with LV ejection fraction. Here are the US guidelines, which essentially divide patients into two groups on the basis of their LV ejection fraction. That is heart failure with a reduced ejection fraction, an ejection fraction of less than or equal to 40%, or heart failure with a preserved ejection fraction, that is an ejection fraction greater than 40%, with a couple of subgroups within this, that is HFpEF with a borderline EF ranging from 41 to 49%, and HFpEF more properly or per se with an ejection fraction of greater than or equal to 50%. Now, the European guidelines handle this a little bit differently in identifying three groups based on ejection fraction: HFrEF, LVEF less than 40%, HFpEF, LVEF greater than or equal to 50%, and that in between group, which is labeled HFmrEF, HFmrEF used to describe this mid-range ejection fraction group, ranging from 40 to 49%. If we look at the epidemiological distribution of heart failure based on LV ejection fraction, you'll see that it follows a bimodal distribution with a peak of around 20 to 25% within the HFrEF population, a second peak of around 60 to 65%, the HFpEF population. But of course, there are many patients in between in that borderline or mid-range LV ejection fraction group. Now, the other major way for classifying or assessing heart failure patients is according to the New York Heart Association functional class ranking, and its definition is shown on this slide. I won't reiterate what's written on this slide except to say that class 1 patients are essentially asymptomatic. They have no limitation of physical activity, and class 4 patients are symptomatic at rest or with any physical exertion. Class 2 and Class 3 represent different gradations of these functional limitations from asymptomatic to severely symptomatic as shown on this slide. But it's important to note that there are challenges in the assessment of New York Heart Association functional class ranking. NYHA functional classification is subjective and has low reproducibility. There is no consistent method for accurate assessment of functional class. In particular, New York Class 2 versus Class 3 is an unreliable predictor of adverse outcomes in heart failure and poorly discriminates among patients across the spectrum of functional impairment. Essentially, we know asymptomatic heart failure when we see it. We know severe heart failure when we see it. But those two groups in between, New York Heart Association's Class 2 and Class 3, overlap substantially, and there is quite a bit of subjectivity in assessment in these two classes in particular. It turns out that in high-risk patients, New York Heart Association Class 2 versus Class 3 carries the same baseline risk of morbidity and mortality. And I'll show you that these two groups are essentially indistinguishable when one considers objective measures of heart failure disease severity. Thus, we are probably misclassifying a lot of Class 3 patients as Class 2. And here are some of the data that support that notion. This slide shows the distributions of objective measures of heart failure severity according to New York Heart Association functional classes 2 and 3. The data come from two large clinical trials, the GUIDED trial and the HF Action study. The New York Heart Association Class 2 patients are shown in blue, Class 3 in red, and starting in the upper left-hand corner of this slide, moving clockwise, you can see results for the KCCQ quality of life score, NT-proBNP, LVEF, and the 6-minute hall walk distance. And you'll note the substantial overlap between Class 2 and Class 3 patients according to these objective measures of heart failure disease severity. So we really ought to be looking at objective measures rather than subjective ones in the assessment of our heart failure patients and the selection of drug and device therapies for their treatment. And I'll just demonstrate one trial that showed that high-risk patients with either Class 2 or Class 3 heart failure really fare about the same, have the same clinical outcomes and response to an intervention, and that is the COAP trial of MitraClip for the reduction of secondary or functional MR in heart failure patients. Here were some of the key inclusion criteria, and here's the bottom line. If one looks at COAP 24-month clinical outcomes by New York Heart Association class subgroups, either looking at the outcomes of all-cause mortality or the combined endpoint of all-cause mortality or hospitalization due to heart failure, you will see that there was no difference in baseline risk or in treatment effect by New York Heart Association Class 2 versus Class 3. How can we better assess the NYAHA class? Well, we can do that by asking specific questions or even using a tool such as the specific activity scale shown on this slide and referenced at the bottom. You can see that one asks more specific questions. How far can you walk on level ground at a normal pace? Can you climb a flight of stairs? Do you have to stop on the way to catch your breath? We can get a better idea of the specific functional limitation in an individual patient. So in summary, heart failure represents a major and growing health problem associated with substantial symptom burden and impaired functional status. Assessing symptom burden and functional status is important across the spectrum of LV ejection fraction. Challenges limit the assessment of NYHA class ranking, but can be overcome by asking specific questions to quantify functional limitations. And finally, partnerships among cardiology subspecialists, general cardiologists, and primary care providers are necessary to meet treatment goals in heart failure patients, to optimize our drug and device therapies to improve both subjective as well as clinical outcomes in our heart failure patients. Thank you so very much for your attention.
Thanks, Prof. Abraham. That's a very nice start to today's session. So I'd like to just do a quick discussion around the diagnosis of heart failure, as well as pros and cons of just a clinical NYHA classification, because that's how we go about picking out the right patients, I guess, even for therapy. Maybe I'll start with Prof. Andrew Coates with his comments first. So we know the NYHA class has a lot of limitation, but it's cheap, it's good, it's well studied. It has its limitations. In your mind, what is the main downsides for NYHA classification? Maybe we'd like to start with that.
Okay. Well, let me say, first of all, heart failure is both the most simple and one of the most difficult diagnoses, because we can all recognize a case of acute pulmonary edema with a large heart and poor systolic function. But many comorbidities make it difficult to see the element of heart failure. NYHA class is useful because it's a convenient way of expressing to each other and understanding just a form of functional capacity assessment. It's an informal estimate of how limited you think a patient is. But quite clearly, heart failure is very complicated, and it has hemodynamic aspect, it has neurohormonal aspect, it has secondary changes in the rest of the body. So no single measure can encapsulate all of those measures of severity. So I think it's unfair to expect NYHA class to be a perfect metric for heart failure. I don't think there is a perfect single metric.
Thanks, Prof. And I guess what the other metrics are is to enrich and highlight and tease out between the NYHA class. David, can I just ask you, how should we use, for example, a biochemical marker like BMP in addition to NYHA class? Do we look at the number, the tertile, and what tertile do you think shifts them into which class, and in what numbers are not then so relevant?
I don't think there's any specific cutoff for NT-proBNP to say that above a certain value, you put them in class 3, or certain value they are class 2. So what I do is I would like usually to do a baseline NT-proBNP when I first see a patient heart failure, and I tend to look at the trend. Generally, the trend is a downward trend, especially if I get the NT-proBNP to less than 1,000. Usually, I know I'm the right track. But for some patient, when it started as high or it started low, but the trend is upward trend, then I get a bit more worried for that group of patient. And I agree with the previous speaker, that you should ask more specific questions when it comes to assessing the NYHA class status. A lot of time we will ask patient, do you feel breathless? How much you can, walk? The problem is a lot of these patients understand they've been living in chronic heart failure for many years. So they're used to this slow pace. So you have to ask more specific question, within a certain time limit, how much can you negotiate in terms of distance? And I start asking them questions about going upstairs and upslope, which give you a better assessment of NYHA class status. Now, of course, if I'm still not sure, I sometimes do send them for more objective tests such as 6-minute walk test or VO2 max. Yeah, if I think they are underplaying or masking their symptom.
Thanks, David. So in more experienced clinicians' hands, the NYHA class status does tease out a lot more and probably is more to the truth. Just one last part about BNP again. So you're saying that the trend is more important. Do you make a decision between a BNP of 500 versus 5,000 then? Is there a real concrete difference?
Obviously, somebody with a BNP of 5,000 is not going to do well compared with somebody with a BNP of 500. If I come across a patient with a, who tell me he's relatively well, not much of a symptom, class 1 or class 2, with a BNP of 500 or less, I know that guy is going to probably do well versus somebody, who is like 5,000, you have to optimize the medical therapy and probably may even need to consider some form of device for him to bring it down.
Thanks, David. Questions from the audience, so I'll just narrate that. From Pericho Madeline, I hope I got your name correct. In CKD patients, what do you do if the BNP doesn't go down actually, despite maximizing heart failure medications and doing dialysis and limiting oral fluid? So you're someone with CKD with heart failure, not an uncommon scenario. Is there anyone in the faculty who is keen to answer this question? Prof. Aziz, you want to?
So it's a very interesting talk about BNP for heart failure patients, particularly those with renal disease. We know that BNP can be a great marker for acute decompensation and sufficing these patients. However, in obese patients, a patient with kidney disease, BNP can falsely either very elevated or lower than normal, and it becomes less of a valuable marker at that time, especially in the idea of titrating it up or down during the management. We know that BNP is a marker of stress on the heart. The heart release it as a diuretic, and the more of it, the more the patient is in heart failure. So, however, it has a lot of faults into it, particularly in the initial management. I typically use it, the emergency room in the United States always get a BNP on admission, right, for every patient. We usually do another one in 24 hours just to see where are we going from the direction. And then, as the previous professor have said, we might do a dry BNP right before discharge to know where the curve of the patient stays for the next admission. However, there are caveats, particularly patient with heart failure, for renal failure and those who are obese.
Thanks, Prof. One last question before we move on to the next talk. Maybe anyone can chip in. Are there no devices that you know of that actually helps classify and monitor the patient life for NYHA class? Because NYHA class moves. I know in a couple of years ago, there was a device, I think it is approved for use to monitor PA pressure live. Is that useful at all? Prof. Coates or David?
Yeah, I mean, the PA pressure monitor CardioMEMS can be very useful for selected patients where hemodynamics is a very important aspect and there's highly change. It's not feasible in very large numbers of patients because you need a network to interpret all these pressure data that are coming through. So it's failed to translate into a treatment for large numbers of patients. It's for selected patients in very selected units in my experience.
Actually, one thing I don't understand is that the EP folks are putting pacing device in the right ventricle, in the right side. Why can't there be a device that monitors as well,
I think that's coming. I think we will see a lot more devices that are multi-purpose in the future.
We know that. Go ahead.
Yeah. Sorry. Yeah. Hi, CK from Singapore. I'm a heart rhythm cardiologist. So there are actually parameters that you can derive from pacemakers and ICDs to predict if that patient goes into an episode of heart failure in the near future. For example, they could measure the thoracic impedance That's a marker of conductivity. If the heart, if it goes up or it goes down, that gives us an idea of the fluid status in the lungs. But from the body of evidence, it suggests that a single marker is not useful. Looking at pure thoracic impedance has a lot of false positive. If a patient goes into pneumonia or other causes, that affects the thoracic impedance, and that's a false positive result. Number one. Number two, so you really need a collection of predictors. For example, a thoracic impedance, heart rate variability, patient's activity, and a whole host of other factors. If you are able to look at the T wave changes with a far few electrograms between the device and the lead within the RV, as a composite marker, if shown to be able to predict a patient who may tip into heart failure in the future. But having all these monitoring devices or parameters is one part of the equation. You really need an ecosystem or infrastructure to react to changes in those parameters and to act on them, which means David has his team of heart failure nurses and allied healthcare professionals who are able to perhaps interview, make some adjustment of medication over the phone when they react to certain parameters. By doing that, you are able to then intervene and perhaps reduce an episode of acute heart failure. So having parameters is one side of the equation. Having an infrastructure and a response system is the other to make it work. Over to you, Jack.
Thanks, CK. That's terrific. In fact, a few years ago, I listened to a lot of talks in this space about monitoring. I thought it's going to come earlier. It goes all the way from direct implants to even a voice recognition on your phone to talk about whether changes in the voice can predict a heart failure onset. So I think it may come sooner than we think, and we don't want Apple to do it faster than Medtronic, for example. So, but that may come. So I think there is another questions here in patients with mobilization walking problem, example post-stroke limb problem. Of course, we can't rely on NHCS class status. How do we then classify the degree of heart failure patients in the immobile subgroup of patient? Questions from Leonardo. David, maybe you'd like to take that. That's a good question. Patient who can't walk. How do you do NOHA class?
Of course, this patient can't walk, it's going to be very tough, especially if they're big bound or wheelchair bound because of maybe muscular skeletal issue or previous stroke. It will become a bit more tough. So I will have to rely on other parameters as well. Like we previously mentioned, you cannot just look at the NOHA class status, you look at the patient as a whole, with the imaging and the so-called biomarker, to guide us in the management of this group of patients. Yeah. So I don't think there's a perfect way of saying, okay, there's only one test that can accurately tell us how severe is the heart failure. You really need to incorporate the history, the symptom, the blood test, and the imaging all together to come to a so-called clinical judgment of which state of heart failure do you think the patient is in.
Thanks, David. Prof, Asmi, your last comment before.
I think in our community, it's actually quite difficult to engage patients to get their detailed symptoms. I think sometimes maybe the community or in some patients who they cannot really express themselves in terms of how symptomatic. So there is a lot of limitations using function class, NYHA class. So for us, I think the physical examination biomarkers are very, very important. We use it quite a lot in our center with regard to biomarkers because, of course, we are able to use it. It is, you use it on admission prior to discharge and also during the hospital follow-up. And these are the biomarkers that we use on top of the symptoms to decide whether this patient requires expensive treatment. For example, Entresto is still sacubitril valsartan and still very expensive. In Malaysia, so these are some of the things that we look into to decide. Of course, there are some centers without the use of biomarkers that might be a little bit tricky. So hence, if their function class is a rather limitation, then maybe they can consider more of physical examination to look at their decompensation, as opposed to just symptoms on its own.
So again, thanks, Prof. Hasmi. I think for the Asia Pacific cohort, just to summarize before I move on to Prof. Coates' introduction of CCM, is that heart failure is prevalent. Simple tools, don't neglect the appropriate history and physical examination because it's cheap, it's good, it's probably more reliable than doing tons of tests. So elucidating the correct science actually is better than thinking of devices straight up. So I think we should never forget that. There is a follow-up question for CCM, but I think we'll defer that to after the next lecture. So we'd like to welcome Prof. Coates to start introducing CCM technology first before we have a discussion. Prof. Coates, please.
Thank you very much. Let me share my screen. And are you seeing it as full view?
Yeah, we're seeing it as full.
Yeah.
Please go ahead.
Okay. So my name's Andrew Coates, and I'm president of the Heart Failure Association of the ESC at the moment. And it's my great pleasure to present at the APSC. I'm presently out in Australia because of the COVID situation. So I flip between UK and Australia. I'll be talking about CCM, which is a very interesting electrical device therapy for heart failure that I believe has an important role in selected patients. We know in heart failure that we have very many treatments. We have more than 10 separate treatments that have been proven to reduce mortality and morbidity. It's probably the area of, or the whole of medicine with the most proven therapies. We have ACE inhibitors, beta blockers, angiotensin receptor blockers, mineralocorticoid receptor antagonists. We have ivabradine, we have sacubitril valsartan, we have ICDs, we have CRT. Now we have SGLT2 inhibitors. We have single trials for vericiguat, omecamtiv mecarbil, and we have treatments for comorbidities such as secondary mitral regurgitation with the MitraClip. So really we have an excess of options. And we can't just simply say every patient needs everything. And yet we all have experience of treating patients who remain symptomatic, remain at high risk, and we'd like to do our best for those individual patients. So I'd like to talk about this one treatment that I think has a role for an important subgroup of patients. Here are my conflicts. So how CCM work is completely different to CRT. It's deceptively similar. It's a pacemaker-like device, leads inserted into the heart. You see there the box. It's now quite a bit smaller. What it does, it delivers a high-frequency stimulation right at the point of the absolute refractory period. So it does not cause electrical depolarization of the heart or a cardiac contraction. It rather primes the activity of the cardiomyocytes. And we've known for a long time by a system called TREPI that if you stimulate rapidly myocardial myocytes, you get an increase in the developed force of the myocytes. You're more triggering a metabolic change and a gene expression that makes the myocyte contractility increase. So at an organ and physiological level, what you get when you do this repetitive stimulation during the absolute refractory period is you change the calcium distribution within the cardiomyocytes, you change phosphorylation of titin, and that can lead to increased contractility. You can normalize key regulatory proteins and their activity and reverse the fetal gene program expression. That can lead to reverse remodeling within a patient with remodeled left ventricular heart failure, and that can lead to secondary changes with a reduction in fibrotic stimuli, a change in autonomic nervous system balance, and a change in the energy balance of the myocardium. The interesting thing is that you require the stimulation not over the whole myocardium, but just in one area, usually in the septal wall. But we see biological effects and altered gene expression remotely from the point of stimulation because you get some transfer of the electrical activity and stimulation, and you get crosstalk between regions of the myocardium. That can lead secondarily with reverse remodeling that can then lead to overall clinical changes, such as improved exercise capacity and potentially a reduction in heart failure hospitalization. Here's an early study from CMU up in Chinese University of Hong Kong that looked at a small series of patients, 30 patients, age 60, 80% male, who have insertion of CCM. They all had narrow QRS, and that's an important aspect of this treatment. We know that cardiac resynchronization therapy can be effective, but it's restricted to patients with prolonged QRS duration, with most guidelines giving the strongest recommendation only above 150 milliseconds. And because of the results of the ECHO CRT study that showed an adverse outcome with QRS durations less than 130, we restrict CRT to above 130, whereas patients with normal QRS durations are amenable to CCM therapy. So this study showed significant reversal of left ventricular remodeling in patients with heart failure and reduced ejection fraction associated with the prolonged and sustained improvement in myocardial contraction. There were some early randomized controlled trials of CCM. It comes from a relatively small manufacturer. It's not a Medtronic or an Abbott. Impulse Dynamic is a relatively small company, so it can't afford to do the extremely large multiple thousand patient trials. But there are a series of trials over a number of years, FIX CHF4, FIX HF5, of which Bill Abraham was a lead investigator, a feasibility study, and then the main study. And you see patients in the middle hundreds. And increasingly and consistently, these trials looked at functional endpoints because they weren't powered in size to look at mortality as an endpoint. And they used probably the best functional endpoint, that is peak VO2 during a cardiopulmonary exercise test. And these trials consistently showed an improvement in peak VO2. There was a nuance because the US FDA at the time required a different primary endpoint of time to anaerobic threshold, which is an unusual endpoint. And that wasn't the most informative endpoint, which is normally, I would recommend, peak VO2. It was interesting that these early studies suggested there was a benefit across the board, but that it appeared that there looked like there might be an even greater benefit in those people with reduced ejection fraction, but not severely impaired, and perhaps a sweet spot between 25 and up to 45%. And I guess that's plausible given the mode of action because it promotes contractility, and you probably need at least some residual decent myocardial contractile reserve to get the best benefit. So then there was a trial called the FIX HF5C, a confirmatory study, and that was given expedited access pathway designation by the FDA, which qualified to priority. It randomized 160 patients one-to-one at both US and EU study sites, and it concentrated on that sweet spot of an ejection fraction between 25 and 45%, with a primary efficacy endpoint of improvement in peak VO2. You see there the results here, and this was an unusual study because it was a Bayesian study. It borrowed some of its powers from the previous FIX5 study, and the FDA approved an analysis that said if you can duplicate that result in a small group, we can combine the two trials. So you see that's why we have a single arm showing a significant increase in peak VO2 that's approaching 1 mil per kilogram per minute, which is larger than the average effect we've seen in most of the CRT trials in the early days. The FIX HF5C, this confirmatory Bayesian study, also showed a significant improvement, 11-point difference in Minnesota Living with Heart Failure questionnaire, and the chance of improving one NYHA class was highly significantly improved in the CCM group compared to the control group. It was not powered for looking at major outcomes. However, there was a very pleasing trend for fewer cardiovascular death or heart failure hospitalizations in the treatment group compared to the control group, which is encouraged and is now subject to a larger prospective study being conducted by Impulse Dynamics in higher ejection fraction patients. If you combine the FIX 5HF and 5H5C combined confirmatory study and you look at hospitalizations and days out of hospital, you see that there was a significant trend to greater benefit in CCM compared to control, and that's both for all cardiovascular events versus heart failure-related events. Now, we performed an individual patient data meta-analysis, and that's probably the ideal form of meta-analysis. And what's good about it is when you get a device with a single manufacturer, you have the chance of making sure you get every single patient who's ever been in a randomized control trial, so there's no selection bias. We did that by searching all trial database in January this year. The sole manufacturer was contacted, and the primary outcomes of interest we wanted to investigate were peak VO2, 6-minute corridor walk test, and Minnesota Living with Heart Failure questionnaire. And we had individual patient and data time point analysis. We identified 5 trials as shown here, and we concentrated on those outcomes. You see here, these are the 5 trials. One of them was a single-arm study, but we borrowed the same control group from the FIX HF5C trial, so we could add that to the database. You see here now the forest plots, looking now at peak VO2, highly significant improvement, plus 0.93 mils per kilogram per minute, a very clinically significant improvement in exercise capacity. We also saw difference in 6-minute corridor walk test, also highly statistically significant, an increase in 18 meters walked in 6 minutes. And we saw an improvement in Minnesota Living with Heart Failure questionnaire. As you will know, a reduction of greater than 5 points is thought to be clinically important. We saw a reduction of 7.9 points in the Minnesota questionnaire. We looked at subgroups to see were there patients who benefited more or benefited less. And for Minnesota Living with Heart Failure questionnaire, there was no real difference between patients above and below the age of 60. There was no difference between women and men in terms of the improvement, and there was no real difference in ejection fraction in terms of the Minnesota questionnaire results between ejection fractions below and above 25%. Also, the etiology, maybe that was the one where there was a greater benefit in ischemic compared to non-ischemic patients. We also looked at peak VO2 as a more objective and quantitative measure, and we looked at the effect of age and found there was no difference between patients above and below 60. We looked at gender, and we found no real difference for women and men. But in terms of ejection fraction, the improvement in peak VO2 was greater in those with ejection fractions above 25% than those below 25. And the 6-minute corridor walk test improvement was also nearly double in those above 25% compared to those 25%. So when we look at the FDA approval and the meta-analysis and the confirmatory study, it suggests that the sweet spot, the ideal patient for a significant benefit from CCM, is a patient with a narrow QRS duration, remaining symptomatic on maximal medical and device therapy, but whose ejection fraction is ideally between 25 and 45%, because that, we believe, allows an improvement in cardiac contractility to be maintained. So in summary, our meta-analysis suggested, based on all the trials, a significant clinically relevant increase in peak VO2, corridor walk test distance, Minnesota Living with Heart Failure questionnaire results, and a very acceptable rate of device and procedure-related complications that was as low or lower than CRT, numerically fewer cardiovascular deaths or heart failure hospitalization, and a stronger effect in the borderline, or what we might now call mid-range ejection fraction. It is a safe, emerging, effective treatment that I believe will be a useful adjunct in selected patients who remain symptomatic with these patient conditions. And I'm very happy to stop there and have any discussion.
Thanks, Prof. I think maybe we jump straight to audience question first before we come back to CCM. It's peculiar to CCM therapy though. Dr. Parajav asks, after implantation of CCM, do you then slowly tail off the maximum heart failure medication and reduce them gradually, or is kept at the same doses?
No, I mean, it's a very controversial point, but the very few studies we've done suggest that with the rare exception of some post-viral cardiomyopathies or peripartum, heart failure treatment is for life. And as far as we know, whole maximal medical therapy needs to be maintained for the rest of the patient's life, even if the ejection fraction improves, even if the patient's feeling well. So we need to maintain all treatments.
So the other observation I have in your presentation was fantastic. It looks promising, but learning from trials, for example, like Simplicity study, firstly, I'd like to ask whether you think a smaller trial needs to have a sham arm for symptom improvement, one. Two, in terms of heart failure trials now, most of the trials do look at harder outcomes like mortality, hospitalization for heart failure, and cardiovascular death. Do you think we are priming this device in the category, or is purely for symptom relief?
No, I mean, time and time again, patient representatives say they want more treatments developed for symptoms, and yet we as a community are obsessed with reducing mortality because we know what it means. So patients say they want symptomatically improving treatments, and we need to do better in that regard. Now, the FDA expedited pathway adaptive design is actually very good because rather like CCM, which was the first device through that, but also CVRX's Barostim, they actually allow early approval and sales on the basis of symptoms and objective measures, but then the company commits to doing a mortality morbidity study. So we get our cake and eat it too. And I think that's very important. So we're not doing an either or. We're looking for a treatment that improve exercise capacity and quality of life, but we also will get an answer on what the mortality effect is. And it may be neutral. That's perfectly acceptable. We don't have to only have treatments that reduce mortality, as long as they don't increase mortality beyond a minimal acceptable risk.
So I understand the inventor of the device also invented the cathode imaging system and tons of other devices.
Shlomo Benheim is a brilliant physicist, manager, as well as cardiologist. He's an amazing character.
And entrepreneur, I get it. So I would like to ask my EP colleagues, what do you think of an implantable device and the touted technology behind it?
I think the CCM is a additional tool or additional therapy for patients or for subselect patients that do not respond to standard or established therapies, including CRTs and the drug therapy. Well, it's a very novel and very interesting idea where stimulation during the absolute refractory period of the ventricles affect cardiac modulation and increase contractility. It's very promising, but I do have some questions. For example, in the fixed HF5C trial, they've shown a significant improvement in the VO2 max and the 6-minute walk test. But the absolute improvement you could see is about 1 unit for the VO2 max, 1 to 2 at most, and an additional 16, perhaps to 20 meters for the 6-minute walk test. My question would be, how significant is that in real life? Would an additional 15 to 16 meters walk in 6 minutes be satisfactory for most patients in our context, or a elevation of VO2 max of 1 to 2 unit be of a significant improvement? So I do see that the endpoints are achieved. This is one question that I have. Number 2 would be in the Asia-Pac region, most patients are rather conservative and are not inclined towards implantation of a device. Let me say that in the Asia-Pac region, the adoption for ICDs and CRT is fairly low, despite established guidelines. So I'm cautiously optimistic about CCM, but looking at the track record in the way we adopt guidelines for devices, I have to check my optimism for this therapy. So I have more questions than answers to your question, Jack.
Maybe I could just come in with the peak VO2. I mean, I did a lot of my research career looking at cardiopulmonary exercise testing, and depends on the background level. So we all have a transplant waiting list. Often we use 14 mils per kilogram per minute as a threshold for consider the need for transplantation. So it depends on the average. And if you have a patient who's averaging 10 to 11, a 1 mil is really a substantial difference. It makes the difference of being able to go up to the upstairs bedroom or not. But I will put it in perspective is that none of our drug treatments have been shown to increase peak VO2 any greater than 1. The only treatment we have that does is exercise training in selected patients. CRT was initially approved for use on the basis of peak VO2 increase, and the average increase in CRT was less than 1. So it's very much in the ballpark of CCM, and that is a clinically useful benefit because that's an average effect over all patients, and it makes a big difference for the class 3 patient who's quite significantly limited.
Thanks, Prof. Maybe I can ask Prof. Aziz comments on some of the questions. For patients on CCM therapy, is there any issues for patients taking certain antiarrhythmic medications like amiodarone or class 3 antiarrhythmic agents that might impair the refractory period?
No, there's actually no interaction whatsoever because it works in the absolute contractility period, so it does not really affect it at all. Going back though to Professor Chi question about people very reluctant to have devices, we face the same thing here in the United States, particularly in our my university is in a very versatile area, a lot of immigrants, a lot of people from Nigeria and so on and so forth, and these patients don't have devices. So CCM comes here and it really puts a little glimpse of light to these patients. A lot of people don't like ICDs, the idea of having some device that will control them at one point or maybe shock them at one point. But however, for those patients with 25% ejection fraction, I always tell them, maybe that device that will make you feel well, and there is a greater likelihood of improving of your heart function with it, with an extended battery life. Patients are more accepting into this rather than telling them, I'm going to give you an ICD. It's not going to make you feel well, but it will make you feel longer. People don't want to feel longer in misery, but they might accept the idea of having a device that will make them improve their life. So that's how I get to these patients.
I might come in. There's a recent interesting analysis done on 2 groups of heart failure patients done by the FDA with the device manufacturers. And they're looking at particularly devices, in this case, MitraClip. And the patient preference was that they would be prepared to trade off a 10% risk of dying to get an improvement in one NYHA class from their perspective, for class 4 to class 3. They'd be prepared to trade 4 years to go from class 3 to class 2, but they'd only be prepared to trade 2% mortality risk to reduce the risk of hospitalization by 50%. So we're obsessed with hospitalization as a surrogate for mortality, but the patients say quality of life, NYHA class, is far more important for them.
Thanks, Prof, for that again. Any experience around Asia Pacific? Ask me, are you doing that in National Heart Institute Malaysia?
Yeah, we are not doing it at the moment. I think, we are looking into it, but of course, one of the questions here, how does is going to translate in terms of economic burden? I think, when we combine, CCM plus medication, of course, the cost implications will also always be there, when we're treating our heart failure patients. Yeah, but we are no experiences yet.
I think the device is coming to some of the Asia Pac countries, so we're quite excited.
Yeah, I think Hong Kong was probably the earliest one in the APAC.
And I think they are bringing into some of the East Asian countries besides Hong Kong as well. So we're excited to hear from our colleagues across Asia soon. I think it'll be great. I think heart failure is not a cheap patient subset to manage if you talk about the best evidence-based therapy. It would be great if you can combine a CRT with a CCM, for example.
That is in development. I can give you the clue.
So you narrow it and deliver another pulse to give it a kickstart symptom relief on top of the CRT therapy.
So CCM and ICD combination. Yeah, ICD. That's definitely coming.
So can I just quickly re-summarize before we go into the case illustration? Any comments from anyone else? David, do you have any comments?
Nothing much. I just wanted to add, in our Asian patient, especially those with smaller build, it's a bit tough to expect them to have both the ICD and the CCM. So I guess because ICD is so much in the guideline, I think most of us will be fearful if you don't offer ICD, maybe medical, legally, we may get into trouble. So I think most of us will probably opt for ICD first. And once the ICD in, I guess it's very tough to have another device on the other side with so many leads going through the tricuspid valve. So that's another consideration as well. So I think until the ICD function and the CCM can be all in one device, I don't see how it can really take off in Asia. Yeah.
So I think the crux is really what is the outcome and the real proven benefit. If it really is effective in improving NYHA class, then I think it will work. So I'm happy to see more data and more experience coming out from Asia particularly. So just to quickly summarize, Prof. Coates, correct me if I'm wrong, the ideal patient for some form of symptomatic really potentially is someone with a more impaired LVEF between 25 to 40% HFrEF patients, maybe more ischemic rather than non-ischemic etiology with a narrow QRS complex at the moment, and already maxed out on all medical therapy for hopefully improvement in VO2 max and 6-minute walk test, maybe an NYHA class. So anything else to add before we go?
No, I think that absolutely captures it. And to come to David's point, if you're contemplating an ICD and you have the combined CCM ICD, then just do both for the sort of hassle of doing one, because then you get symptomatic benefit as well as protection.
Okay.
When that comes.
Thanks, Prof. Aziz. So we'll move on to the case illustration to close up the sessions, and we'll discuss around the case instead. So Prof. Aziz, maybe you'd like to show us your case now.
Sure. Thank you so much for the invitation. And as you know, it's very early morning here, so excuse my clearing of my throat as if I speak. Well, I'm going to, as we've mentioned earlier, this is the indication for CCM and heart failure patients. Optimizer Smart System deliver cardiac modulation therapy, and it's indicated to improve 6-minute walk distance, quality of life, and functional state status of New York Heart Association Class 3 patient who remain symptomatic despite guideline-directed medical therapy, who are in normal sinus rhythm and have a left ventricular ejection fraction ranging between 25 and 45%. I just want to say that in the initial trials, patient had to be in normal sinus rhythm because there was an atrial lead in the device. And now that the atrial lead is no longer indicated, maybe there may be looking into patients with atrial fibrillation. It doesn't clear the indication yet, but maybe the future. This is how the device look like, and it has these coil that allow it to be charged. This is a charger.
Aziz, are you sharing your slides, because we don't see any slides at the moment?
Oh, sorry. Maybe.
No problem. It's good to just hear from you, but it'd be good to see some slides.
Sure. Let me do that. Somehow I thought I was sharing, but I guess I went ahead of myself. You see it now?
Yeah.
Okay.
It's coming on, so there's a lag. I think. Yeah, we see it now. Please go ahead.
Okay. Wonderful. So as I said, symptomatic patients, despite being ungammed and normal sinus rhythm, EF 25 to 45%. And as was mentioned earlier, in the early devices, there were a port for atrial lead. In the later trial, the atrial lead have been not necessary, and it showed that the 2-lead system is as efficacious as a 3-lead system. So maybe there will be an indication in the future for patient with atrial fibrillation, and that won't be a limitation. Patient get a smart charger. The device has to be charged once a week, and that's the programmer that is used during the implantation. So CCM is typically implanted done in the right side. So we prep the patient from the right side. And the main reason is there's mostly there's a concomitant device implanted on the left side, either a pacemaker, ICD, or a CRT device. Obviously, as mentioned earlier, there are works now of having a combined system. And once we have that combined system, there will be no need to implant it on the right side. So here is 3 patients that I implanted CCM in. I'm just going to give you a little slew of how the patient selection came up. This is Mr. Jones. Obviously, the names are not the same, but 60-year-old gentleman with medical history significant for a hypertension, type 2 diabetes, and a systolic heart failure of ejection fraction of 28%. Patient had an ICD. However, he had 3 admissions of heart failure in the past 9 months. And his EF had remained 28% despite being an optimal heart failure therapy with New York Heart Association that remained in class 3. So there was one more patient. I don't know what happened to the slide, but typically a patient like that will be indicated for CCM therapy. So most of these patients will be evaluated and approached for the CCM therapy. And I'm just going to walk you through one of the cases and how do we do it in the lab. It's a very routine implantation, like you implant any device. These patients will be done under conscious sedation because they need to be arousable toward the end of the procedure to check on the comfort level once the therapy is on. Remember, we are stimulating the heart at 7 millivolts, so you want to make sure that the patient is not feeling this when we turn the device on. So we, toward the end of the procedure, we arouse the patient and do what we call a comfort test to make sure that they're not symptomatic or not feeling any abnormalities. So it is implanted under local anesthesia with conscious sedation most of the time, except in very rare cases where the patient is either young or psychologically not sound or mentally fragile, elderly patient who cannot be kept on the table without deep sleep anesthesia for required time of the procedure. And the procedure typically takes about 35 to 40 minutes to implant. So it's typically implanted in the right pericardial area, and as seen in this image, where we do the ideal incisional cut that's done in the infralateral area here, and the pocket for the optimizer is created infraclavicular space and kind of extending down medially. I typically access the axillary vein outside the chest wall. It just minimizes trauma, it minimizes pneumothorax, and it minimizes any trauma for the leads, really, rather than, I know a lot of people do cephalic, which comes up here, but whatever access you prefer, you can do. And typically 2 wires are then passed over using Schlindinger technique. There are multiple leads that are approved to be used with the CCM. They don't have their own leads yet, but they are under testing now. So any bipolar standard IS-1 lead will be okay. These are regular pacemaker leads. You can use them with active fixation and with a maximum total wire resistance of more than 200 ohms. These are the approved leads to be used with optimizer system. The Abbott Actually, the 4 major companies have approved leads that can be used with the optimizer, either Abbott, Biotronic, Boston Scientific, and Medtronic. So early device implantation, as I mentioned earlier, had an atrial lead for atrial sensing, which would be positioned in the right atrial appendage. However, fixed HF5C2 showed that 2-lead system had the same safety and efficacy as 3-lead system. And in October 2019, the FDA have approved the 2-lead system, which really minimized the amount of leads that we put into the heart, particularly if the patient have another device in the other side with multiple leads as well. So typically, an introducer is advanced over the guide wire, and a bipolar active fixation lead is advanced under fluoroscopic guidance to the right ventricular apical septum. And then a second bipolar lead is implanted about 2 to 3 centimeters above the first lead, with a gap between of them. Average is about 3 centimeters or about an inch. Ideal lead position are anterior position and in posterior position on the septum itself, have a way between the base and the apex with at least about an inch between the two of them. We definitely try to avoid right ventricular lateral and anterior free wall to prevent perforation. This is a little trick that I use, which I'm sure all electrophysiologists use, to get into the septum from the right side. Is not that easy without reshaping the stylet into that reverse S shape. It helps position the leads and navigate it to the septum of the right portion of the septum very easily if you pre-shape your stylet to get into the heart. This is the ideal position. So this patient have an ICD, and you can see the ideal position of the 2 leads. They are in the mid-septum right here, with about an inch separation. This is appropriate in the septum with the appropriate separation. This is inappropriate either anteriorly or laterally. You worry about perforation, obviously, and in addition to the perforation that you worry about, is you're not delivering into the main bulk of the muscle. The whole idea of giving the septum is the septum can distribute that electrical activity and the efficacy of the CCM therapy to the rest of the myocardium, which is the rest of the left ventricle, rather than just sitting into the right ventricle. This is lead placement in details. This is an AP X-ray, and you can see the relationship between the 2 leads versus the IC lead. That gentleman had a 3-lead system, so the atrial lead was there. This is an RAO position, and that's your LAO position. Really tell you very well that you are very septal, that you are not in the free wall, you're not in the lateral wall, and it will show you the separation between the 2 leads. That's a perfect implantation, actually. This is an X-ray with a patient who have ICD. This is a Biotronic system. Again, you can see sitting in the mid-septum with the separation here. And that's another patient who had a Medtronic ICD here, again with the CCM, and you can see the ICD lead is here, CCM is mid-septum with the position. I just wanted you to see a difference from some of the patients that we implanted and how does it work when you have another device on the other side. Lead connection. So once you implant the leads into the septum, you have to test the leads. So we test them like we always do with any pacemaker. You test the sensing and the threshold. Obviously, you want to have a sensing of above 5 for the ventricle, and you want to have a threshold under 1. And when we implant the device, you have to make sure that the coil on the device is facing the skin, because that's how the patient can be, the device can be charged. So we use it, as I said, we use the PCA to test the leads, and after that we put the leads into the Omni programmer, and that will tell you which one is the right ventricular. Both of them are in the right ventricle, but one of them is the sensing, one is the delivery for the therapy. And that's the coil, and the coil have to be facing the skin, as I said, and the device should not be very, very deep. Especially in a very obese population. So try to be under 4 centimeters to the skin to allow for the interaction and the charging. Once you cap, you're gonna put a port pin plug to plug the atrial system. The newer ones will come only with the 2 leads. And then you implant the 2 leads. Will tell you, the rep, which one to implant where. The RV is typically in the middle. The LS is the lower port, as seen in the diagram in here. And this is what a programmer will look like. It's used to verify the lead positioning. It will tell you also where the delivery. It looks at the LS segment, and it looks at the appropriate timing for therapy delivery. As you can see here, that's the amplitude of CCM therapy and the duration of doing it. So here is a sensing of the ventricle. This is the LS window. When it looks into that LS cycle, we call that the alert window, and it looks at these spins to locate exactly that refractory period and the time that where is going to deliver the therapy at. So patient comfort during the CCM stimulation is very important. If the leads are not on the septum, there is the possibility that the CCM stimulation will be felt by the patient. After the leads are placed, the leads is connected to the device, and the CCM is activated in order to test for the comfort level. After we do this, we do a crosstalk testing between that device and the ICD, if the patient have an ICD. Obviously, if there is crosstalk, you run the possibility of having inappropriate shock by sensing it. So there is a crosstalk portion in the programming here that can be adjusted to prevent sensing from the ICD during the CCM delivery therapy. Post-operatively, we ask the patient not to move the arm of implantation above the shoulder for about 2 weeks to prevent the lead movement. We ask them not to, the regular things that you tell anybody with IPG implantation, not to lift anything heavy for about 4 weeks. And post-op, patient is followed up in the office for about 2 weeks to look at the wound and so on and so forth. Obviously, we like to tell the referral physicians that your EKG now might not be normal. You will see the CCM therapy delivered at the tail of the QRS, as you can see here, and that's a typical EKG with CCM therapy delivered. And it's as you can see, it's a 7.5 volts delivered for about 20 millisecond duration. A patient is instructed to charge the device once a week. What happens is that typically my nurse practitioner will adjust the phone of the patient to the football time game on Sunday. So she would do that for about half an hour. The alarm will ring, and the patient is instructed to go to put the wand on the shoulder while they're watching the football game. And like that, we make sure that the device is charged. The therapy is delivered as a 1-hour therapy delivered, separated by about 4-hour rest. So the patient gets 5 sessions during the day, and the device is charged weekly, as I said, and the longevity of the device is about 15 years. Routine office visit, like you do with all your IPGs, typically twice a year. Possible alarms that can happen from the device if the battery charge is less than 70% or the lead impedance, there is a discrepancy. Up to date, there is no diagnostic yet, meaning there is no remotes for the patient to take home with them, and it's not MRI conditional yet. What do you expect? minutes after implantation, and we've seen the slide before. You see a local electronic spread of the signal, rapid phosphorylation of key proteins. I want you to think of it as, I always tell people, remember you have a beautiful bottle of champagne and it has a corkscrew on top of it, right? In order for the bottle of champagne to work, you have to open the corkscrew. The calcium channels are blocked by the phospholambam sitting on top of it, preventing the calciums to enter the cell very well. So what this therapy does, it phosphorylates the phospholambam, allowing the cork to leave the calcium channel being open, and then the SERCA gene can work very well. And actually what it does over time is it upregulates the SERCA genes. So shift in upregulation of heart failure from heart failure status to normal status, local effect improve in contractility of the global level, and from weeks to months you see benefit effect in the global ventricular reverse remodeling, as we heard before. This is a very nice slide, courtesy of Dr. Kawash from Ohio State, and you can see the patient population that benefits from CCM. So anybody with EF less than 35% with a wide QRS, these population get CRT, and patients who have normal QRS but EF less than 35, these patients might get an ICD. However, those patients who, despite of having CRT or ICD, but EF remains between 25 and 45, CCM therapy works very well for them. The potential expansion is patients with preserved ejection fraction, and there's a lot of studies going into this population. So in conclusion, based on the totality of clinical data on New York Heart Association Class 3 heart failure patient with reserved ejection fraction and middle ejection fraction ranging between 25 and 45%, CCM improved exercise capacity, quality of life, and functional status, shows strong trends towards improved morbidity and mortality, especially reduction in heart failure hospitalization, has an acceptable rate of device procedure-related complications similar to ICD or CRT. Effects are seen in both HFrEF and HFmrEF groups. CCM is a valuable addition to our armamentum for treatment of heart failure, especially in those with HFmrEF, where no effective drug or device therapy exists. We are currently on the post-approval study now using the device, the current device that I showed you earlier. In mid-2020, we're going to be using the smaller device. As you can see, we call that Optimizer Smart Mini. This is the Optimizer Integra, which is the device that includes the ICD with the CCM therapy in it. So the future is interesting for heart failure patients. And with that, I cap up and I say thank you so much for the invitation.
Thanks, Prof. Aziz. That's a very comprehensive case illustration, as well as final conclusion. I love it. Maybe I'll welcome you to stop share for a time being for your slide deck.
Sure.
And it was a bit too technical for non-implanters like me. So maybe I would like to Dato Asmi as well as Chi Kyung to comment or ask questions.
How can I stop share? Here. Sorry.
Thanks.
Yeah, hi. So Dr. Aziz, thank you for the very elegant presentation. As mentioned, I think in simple terms, it is not that different from a device implantation. For the time being, it's a right-sided, right pectoral device implantation for those who may benefit from this therapy. And there seems to be little possibility of interaction with current ICDs, and that can be overcome by standard programming measures. Yeah. Of note, the additional step is to make sure that you do a comfort test at the end of the procedure so that patients do not feel the electrical stimulation on the chest, so that even though they may improve in their exercise capacity and tolerance, they will blame us if they get this vibration and funny sensation in the chest 8 to 10 hours a day.
Sure.
Dr. Asmi, any comments?
Yeah, I think the implantation, I'm not an implanter, but I think the implantation looks rather, straightforward, isn't it? I think, from all the implanters, I think, watching here. So I think the idea of it is the mechanism is 7 hours over 24 hours. That's when you actually, has this impulse, isn't it? 7 hours over 24 hours, yeah. So in a way, and it is chargeable from outside. So I think that's also a very attractive point, with this device. Very interesting. And I think, the presentation was elegantly. Thank you very much, Dr. Aziz,
Sure.
Professor, for your presentation.
Sure. Yeah,
David?
I think one of the things that are very important is that device, once implanted, the battery life is the longest that we have now in the market. So 15 years is really long. The inconvenience of charging, maybe some people say, oh, I don't want to charge anything. But some people feel like they're actually participating in the therapy. So we use it as something where we can encourage people, you know what, you're doing something to help your heart.
We can use it to charge your iPhone to reverse charge it out. Yeah, if you're short of battery. David, can I ask whether you have any questions or concern with the multitude of heart failure drugs? Do you think, where do you find the niche for this, and when would you even consider this device?
Yes, so we do know that nowadays there's a lot of option for heart failure treatment. So I think like all devices, you need to choose the right subgroup of patients, subset of patients for it to work. So I think very clear cut, just like the mitral clip, this device, I think you should not be using the very advanced heart failure patient, though is very severely depressed, ejection fraction less than 25%. I think that group, they have no more contractile reserve. So what they need is a heart transplant or a left ventricular assist device. So because we are talking about, boosting the contractility, so you need to have the reserve. As for which group of patients will benefit, I guess, unfortunately, the field of heart failure is moving so fast. Whenever we have device, but now with all the new medication on board, I'm quite sure most of the earlier trial that was done in the CCM, they were mainly in patients with ACE inhibitor and the usual beta blocker. But now with SGLT2 inhibitor, the Entresto on board, how much more benefit will this device give in the regards of modern medical therapy? That I guess we will need more real world data. It's like a lot of time when we see a presentation, when we see patient, when we see that optimal medical therapy, the word optimal medical therapy, the goalposts have shifted quite a lot the last few years. So what I consider in somebody with just ACE and beta blocker, probably not. I would make sure that patients try on Entresto, SGLT2, beta blocker, and the MRA, and the dose optimized. And then if they're still symptomatic, then I would consider a CCM.
That was exactly the question that was just asked by our attendees. Do they need Entresto to be on board before CCM? You answered it before they could ask it. So that's great. Maybe we are come to an hour. We have to stop our close. I will ask each of my faculty and panelists to provide one teaching point before I summarize. So we'll start with Prof. Aziz for this session. Anything at all peculiar to the session or not? It's fine, just one point.
Sure. I want to thank you so much first for including me this morning or afternoon. What I can say is CCM is a very promising therapy. It's an addition therapy to medical therapy, so you need to be optimized. The validation of the point of having such newer therapies like Entresto is very important. It absolutely have changed. It's a paradigm change in heart failure therapy. So with the new trial that's going on now, post HARC trial, we will see the effect in addition to Entresto. Most patients are Entresto now. So the near future is bright for heart failure patients, and I hope that we can answer your question maybe in about a year.
Thanks. Chi Keong?
All right, I think the one take-home message is that it is difficult to assess the functional status of a patient with heart failure, especially those in class 2 to 3. But we make use of current tools in a simple way, And if it's done consistently, it will be a consistent assessment for your set of patients. So I think I really look forward to something more objective than the NYHA 2 and 3, which is very subjective in our clinical practice.
Thanks.
Over to you, Jack.
Dr. Asmi?
Yeah, I think it's a very interesting era of heart failure treatment at the moment. We have newer treatments, SGLT2 inhibitor, and of course, Entresto, sacubitril, valsartan. I think before we even think about any devices, we should optimize the medical therapy first. And of course, the other thing is, in this subset of patients, we need to also consider ICD, which is also a very expensive device for our patients. But nevertheless, I do believe there is a potential, for CCM in some of our patients, because there are some patients who doesn't improve, symptomatic doesn't improve, pro-BNP still elevated, despite you have putting in on Entresto, maybe SGLT2 inhibitor, despite that they are still symptomatic. So maybe this subset of patients, so selection of patients is very, very important. And I think number two for me is I'm more excited to see whether the potential in patients with heart failure with preserved ejection fraction. So I think that is where we have a lot of gap in terms of our treatment. So if that is proven, and I think it will be a big big market for our patients, and of course can be potentially improve our patients with heart failure with preserve. Yeah, thank you.
Thanks, Dr. Asmi. David?
So as we always say, medicine is both in science and art. So I think it's good to have a new, technology, new breakthrough in the science, in fact, in new science, that we now have newer option for patient. But I think the difficult part, which is the art part of medicine, is how to choose the right group of patient, and importantly, not just the right group of patient, at the right timing as well. It seems that CCM, I think just as CRT, must be applied to the patient at the right timing, not when they're too well, and also not wait till they're advanced heart failure when, it's definitely not going to work. So you choose the wrong timing, it's not the technology, it's not good, because you have missed the so-called the opportunity to intervene. And of course, if the company do hear it, we also prefer the right pricing as well.
I think that was the take-home message, David. So allow me to close out my observation. I think I enjoyed myself listening to all the speakers from diagnosing NYHA class status. I think NYHA class status is still, although subjective, cheap, good, and we all understand it well. To do it well, we do need to understand the nuances, do spend some time illustrating history, as well as add on the physical examination before you label it. I think it's still an extremely valuable tool before you move on to adding on bloods, investigation, and other things like where in Asia, a lot of us do not have those resources. When it comes to devices, I think we do need to exhaust all forms of standard guideline-directed medical therapy for a certain period before you consider devices, except I think ICD does have a role and is proven to be life-saving in the HFrEF part. I like the thought that there are a lot of therapies out there. We need to be a bit more open-minded. To this day, we do not know the exact mechanism of action for SGLT2 for its myriad proven benefits. For all you know, calcium channel or neurohormonal benefit is part of its action that we do not know about. So I think an open mind is good. I like the fact that people are still hitting it hard in terms of improving outcomes for mortality, symptoms, and which class, whether it's through devices or drugs. So I think we still need more work and effort. There's always a niche group of patients that will benefit from a subgroup therapy. We probably will take more time to elucidate this. I like the fact that Asmi talked about HFpEF. If really you have a device that people will kill for symptom improvement, is in the HFpEF group. So I think we'll wait to see more of that coming up in our last, I would say, frontier for heart failure group, our HFpEF group of heterogeneous patients. So I'm very excited. I think it's a great time to be a cardiologist, particularly a heart failure cardiologist. I think they have so many things, so many new toys as well as meds at their disposal. So with that, I'd like to thank everyone and keep safe for this period. Hopefully you get your vaccine soon as well. Thank you very much, and thanks for spending the hour with us. Bye-bye.
Bye.
Bye.
Thank you.
Thank you.
Bye.